Hello everyone, and welcome to CRAMsurg, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMsurg from the wonderful region of the Yorkshire and the Humber.
Welcome back, everyone. Today we are going to have a look at a paper about tumor size and prognosis in colon cancer, published in World Journal of Surgery. Following that, I will have a brief chat about ANOVA, or analysis of variance, continuing a series of lectures with demonstrations on how to run your own statistical tests. I'll leave you to it.
Welcome everyone to today's journal review. Myself, Constantine, and Pratik will be presenting this article titled Impact of Small Tumor Size on Prognosis in T3N1 Colon Cancer. We chose to review this article because the authors presented an interesting findings in which they reported that small tumor size confers worse prognosis compared to larger tumor in a subset of stage 3 colon cancer. This is like a direct opposite of the general knowledge that larger malignant tumors confers worse prognosis. I would hand over to Pratik to present the background behind this and the method of the study.
Thank you, Constantine. So we'll talk first about the premise of why they did this study. So we know that the T-staging in colorectal cancer considers the degree of vertical tumor invasion across the different layers of the bowel wall. However, recently, the relationship of tumor size to prognosis has gained attention. Tumor size has been reported to be inversely related to prognosis in certain populations, such as stage 2 or T4 colonic cancer in the last decade. Also, tumor size has been reported to improve prognostic prediction in T4A colorectal tumors. The other thing that they're talking about is the validity of setting shorter than conventional course of chemotherapy. Shortening the course may result in reduction of side effects, but also result in poor oncological outcomes. Of the lower risk cancers, individuals with T3N1 tumors have a worse prognosis than T1 or T2N1 tumor. However, detailed prognostic factors for patients remain unknown. So in this regard, the authors aim to investigate if tumor size is related to prognosis in this subset of colorectal cancer patients, that is T3N1. This is an observational research and a retrospective cohort study, and it compares the outcomes between T3N1 colorectal cancer patients with tumor size less than 45 millimeters versus patients with tumor size more than 45 millimeters. So talking about the methods, it was carried out in a single center as in a retrospective fashion in Japan between the period of January 2010 and December 2021. All patients undergoing colorectal resections were considered, from which 162 patients with T3N1 cancers were included for this study. 70 patients with tumor size less than 45 millimeters were compared with 92 with tumor size more than 45 millimeters. This optimal cutoff value was calculated through of the tumor size was calculated through a receiver operating characteristic curve analysis. Fisher's exact probability test and Mann-Whitney U test were used for comparing the categorical variables and continuous variables. Survival data were analyzed using Kaplan-Meier curves and log-rank test. A multivariate analysis was conducted using Cox proportional hazard model to evaluate the prognostic factors for overall survival, recurrence-free survival, and cancer-specific survival. P-value of 0.05 was considered less than 0.05 was considered to be significant, and the statistical data were analyzed using JMP software. So again, looking at this flow chart, the overall cohort of colorectal cancer patients from this institution was 1596 patients, from which stage 3 colon cancer patients were 453, excluding patients with N2, N3 disease, other than T3 disease and multiple colorectal cancers. The patients with T3N1 disease were 172, from which 10 were excluded due to missing data, and 162 patients were included in the final study, of which 70 patients had a tumor size less than 45 millimeter, and 92 had a tumor size greater than 45 millimeter. Just before moving on, I'll just say in the methodology, how they measured the tumor size was the surgeon doing the operation on the tape after the resection measured the tumor size before putting it in formaldehyde and sending it off to the labs. So now handing over to Konstantin to talk about the results and the implications for the study.
Thank you, Pratik. Looking at the patient and the pathological characteristics in this cohort, 55.6% of them were females. Left colon tumor was about 62.3%. The median tumor size was 45 millimeters. The largest tumor size recorded was 130. About 80% of the patient had minimal invasive surgery for their colectomy, and 20% had open surgery. Most of the patients, accounting for about 88%, had well-differentiated, moderately differentiated, and papillary variant, which confers good prognosis. And about 11% had poor prognostic histological variant. D3 lymph node dissection was done for 90% of the patients, and 64.8% received adjuvant chemotherapy after their surgery. The median follow-up for this study was 55.3 months, and the last patient was followed up to 121 months. So the 162 patients in this study were grouped into two based on the median tumor size of 45 millimeters. Those with tumor size less than 45 were 70 in number, and going forward, I'll refer to this group as the small tumor size. They account for about 43% of the patient. And those with tumor size equal or greater than 45 millimeters, which I would refer to as the large tumor group, accounted for 57% of the cohorts. The baseline characteristics were similar for both the large and small tumor size, except for the histological variants. So those with smaller tumor had 2.9% of them had the variants with poor prognosis. That's mucinoid, signet ring, and poorly differentiated tumor. While in the large tumor group, 18.5 of them had these poor histological variants, and this is statistically significant. Also, the BMI among those with large tumor was higher than that of those with smaller tumor, and this is statistically significant. The overall recurrence rates in the study for those with the group with the smaller tumor was 25.7%, and those with large tumor was 12.0%, and this is statistically significant at p-value of 0.037. The cumulative recurrence rates, looking at this chart, the red line is for those with small tumor group, and the blue line is for the large tumor group. The difference is statistically significant at p-value of 0.032. This graph shows the overall survival in A, recurrence-free survival, and the lower one is the cancer-specific survival. The blue line is for the group with the large tumor, and the red line is for the group with the small tumor. For the overall survival, the group with the large tumor had 94.8% compared to those with small tumor of 84.8%. And this is statistically significant at p-value of 0.03. For the recurrence-free survival, the large tumor group had recurrence-free survival of 87%, and the small tumor group had recurrence-free survival of 72%, which is also statistically significant. And we could see similar trend in the cancer-specific survival, in which the large tumor group had 97% survival compared to the small tumor group with 87.7%, which is also statistically significant. This table shows the univariate and multivariate regression analysis for the factors predicting overall survival. What concerned with the one I have highlighted, which is the tumor size. And what this shows is that for the small tumor group, the Cox proportional hazard ratio is 6.7, which is statistically significant. And this could be interpreted to mean that the group with the small tumor 6.7 times more likely to die from all-cause mortality over the follow-up period compared to the group with the large tumor size. For recurrence-free survival, the hazard ratio here, which I've highlighted again, is 2.1 and is statistically significant. This could be interpreted to mean that the group with the small tumor are 2 times likely to have recurrence over the follow-up period compared to those with the large tumor size. And lastly, for cancer-specific survival, the hazard ratio is even higher at 10.1. And what this means is that the group with the small tumor size are 10 times likely to die from cancer-specific cause compared to those with large tumor size. The authors have reported a couple of limitations for this study, which include the retrospective nature of it and all the biases associated with that. They had small sample size and is a single institution study. 35% of the patients did not receive adjuvant chemotherapy after their surgery. But looking at the table on both sides, it was comparable. So I don't assume this should affect the outcome. The type of chemotherapy and intensity was also not reported. And of importance is the cancer biology, which is known to affect prognosis, which has not been reported in this study. Other limitation which we thought could possibly affect the outcome is the likely significant inter-observer error. The specific manner in which the measurement of the tumor size was done is not clear. Was it cut open? Was the bowel cut open and the tumor measured internally or externally? That was not clear. And if it's measured externally, it will be difficult to get the exact size of the tumor. The resection margin was also not reported, and this confers prognostic value. And we think that this study is not likely to be generalizable based on the overall nature of the study. In conclusion, the authors have asserted that small tumor size has a potential to become an additional predictor of prognosis in this subset of colon tumor, and further research is needed to confirm their findings. Our takeaway or perspective from this article is that in terms of the technical and methodology applied, the good things, they had homogeneous cohorts which could help to make the study useful for that particular subset of patients. The average follow-up was considerable at 55 months median follow-up, which is nearly 5 years. And we know that recurrence in colon cancer is common between 3 to 5 years. And they applied appropriate statistical tool in the analysis. We've stated that this is retrospective study and other information in the limitations. Clinically, we think that if this study is to be applied clinically, then it may be used to personalize patient care while having discussion with patients as regards adjuvant chemotherapy or other form of therapies they can have, or the risk of recurrence after surgery. And in terms of the clinical utility at present, the study would confer or have very limited clinical utility. And I would say thank you for listening.
Just a brief summary of what we discussed during our paper discussion as usual. We had a number of slight issues with this paper, starting from the methodology aspect. We felt that we did understand how the authors wanted to split groups into two between less than 45 and more than 45 millimeter tumors. We also felt that perhaps using this variable as a continuous variable in a multilinear model such as Cox regression analysis would have possibly been more useful to determine if increasing tumor size actually related with the reduced prognosis. Furthermore, we noticed that there are some variables that have been classed that are not statistically significantly associated with prognosis on univariate analysis, but they then become statistically significantly associated with prognosis on multivariate analysis, which is rather unusual and perhaps difficult to come to terms with from a statistical perspective. We then went on to discuss the expert domain. Let's not forget, first of all, that these tumors have all penetrated to the same depth. It is not unreasonable, therefore, to assume that a smaller tumor that penetrates deeper than a bigger tumor would be more aggressive from a biological standpoint. Obviously, this would still be an assumption, but would very much justify the findings of the paper. We also pointed out how there are a number of pathways that can lead from normal chronic mucosa to cancer, and depending on the pathway that is taken, the tumor can be more or less aggressive and be characterized by different types of mutations. And that's why mutational analysis is essential when looking at prognosis on colonic cancer. And we did find that this was a significant piece of data missing from this paper. We also felt that the sample size was perhaps limited. In the space of 10 years, there are stage 453 stage 3 colon cancers in the institutions taken into consideration. This would be the size of a small DGH in the UK in terms of cancer volumes. We'll flag all this to the authors and we'll keep you posted. I'll leave it to the lecture.
Yeah, as I said, we are going to carry on our series on statistical tests, how to do them, roughly what they are. Try and keep it simple. As I said numerous times now, I'm not a statistician or an expert in statistical software. I just like to play with these things. And I find it quite useful in my career, so I thought I should share it with you. Let's have a quick look at what we talked about last time. So last time we talked about assumptions. For a very quick refresher, an assumption is basically something you assume to be true about the data you're analyzing. And it has to be true in order for that particular test that you've chosen to work properly. And the two assumptions we talked about last time were normality, that is to say the data follows a normal distribution, and scarcity, that is to say that the samples that you are comparing have a comparable variance. And I hope all that sort of sounds familiar after the talk from last time. We talked about students T. Now, just a brief refresher, students T, when you have two continuous variables, is a test that you use to determine whether those continuous variables belonging to two different samples are statistically significantly different or not. And I showed you how to run it with Jamovi. Now, as we said last time, the plan is to carry on talking about continuous data. We're still talking about normally distributed data. And today we're going to talk about ANOVA, or analysis of variance. And again, we're going to do that with Jamovi. Usual QR code if you want to snap it to have a look at the Jamovi website. Great software, completely open source, freely available to run all your stats on your own. Very user-friendly, as you will see. So let's talk about ANOVA. ANOVA is one of the many products of Fisher. Now, Fisher presented a work related to analysis of variance back in 1921, when he was working, guess on what? On crops, similarly to what, well, student, so to speak, was doing. Now, Fisher is famous for a number of things. If you have a look on Wikipedia, this is the list of things he's known for. Some of them, and quite a lot of them actually, have to do with statistics and math. And he's kind of considered one of the fathers of biostatistics, really. We still use his tests routinely, Fisher's exact test, etc., and a number of others. He's also slightly less glamorously famous for his positions on eugenetics. But I will leave you to dig into that on your own time. If student T was about two samples of continuous variables from two populations, ANOVA generalizes that to more than two. So if you have three or more samples representing three or more populations, you're asking yourself, how do I know if these three different samples really belong to three different populations and are truly different from each other? A typical example that Fisher was coming across was, well, I have three fields of barley and I've given each of them a different fertilizer. And I want to know if the barley that comes out is better with one of them, or different anyway, or if the actual fertilizer makes absolutely no difference whatsoever. And that's kind of where all of this is born, so to speak. And the key concepts that you need to grasp to understand how ANOVA works are within group and between group variability. So you have a batch of barley. Within that batch of barley, there'll be some grains that are better than others. There will be variations within that group, and that's called within group variation, and is measured through variance. So a mathematical variable associated between, but basically is calculated from the difference between each value and the mean within that particular group. The second important thing to remember is between group variability. which basically means what's the difference between the different means of the groups. So if I got 3 groups of barley, each of them will have a numerical mean for a particular value. What's the difference of the mean of group 1, 2, and 3? Okay. And if you want to represent it graphically, between group variation, again, has to do with the difference between the different means of each population you're considering. If you're looking at within group variation, it has to do again with the variance within that particular group. Does that make sense? I hope it does. But feel free to pop a message in the chat if I'm talking complete nonsense and you don't understand what I'm talking about. So, bottom line, ANOVA works because for a certain amount of within group variability, you expect a certain amount of between group variability. So if really you have 3 batches of barleys that have been taken from the same field, you would expect that their variance will be similar, although it will not be identical, and that to the variation within each of those 3 samples of barley, because they come from the same field, will correspond a certain degree of variability in the means of those 3 groups. If, on the other hand, the 3 batches of barley have been taken from 3 different fields, have been fertilized with 3 different fertilizers, there will be a variability within the groups, but its relationship with the variability between the groups will be different. So if there is too much of variability between groups in comparison to the variability within the groups, then it means that those samples you're analyzing are actually from different populations. I hope that makes some sort of sense. Sorry. So, as we said, when we run a test, we look at assumptions. Normality is still very important. We talked about it last time. We're going to talk about it again. Whenever you're running this particular type of test, ANOVA, you're assuming that the continuous variables you're analyzing lie on a normal distribution. You're also assuming that their variances are relatively similar, so they are almost stochastic. Now, I appreciate that some of this concept I've elaborated on a lot in the previous session, so I'm not going to go into details, but please remember they're very important, and I'm happy to elaborate after the presentation if you want me to explain it again. There are other assumptions. Obviously, the samples are randomly selected. The sample needs to be big enough. How big is big enough? That's always difficult to say in statistics, and there's different opinions out there. And obviously, they need to be independent from each other. So you're just taking them from 3 different, again, 3 different fields or 3 different populations, okay? So, quick recap of why we're doing this. Well, we do ANOVA when we have 3 or more samples of continuous data, when the data that we've got is normally distributed, and when the samples that we have collected have comparable variances. So again, continuous data, normal distribution, homoscedasticity. So let's give you an example. As you probably recall from the previous sessions, for my dissertation, I was looking at retweet rates versus tweets published by publishing journals when they're advertising their publications on Twitter. So for the purposes of that work, I have collected data about tweets that these journals have made and how many retweets those tweets attracted. Now, in this particular scenario, I want to know if different tweeting journals affect the number of retweets that that particular tweet is getting. So again, I've got 6 publishing journals. Each of them is associated with continuous variables, which is the number of retweets. I hope that makes sense. So let's have a go. And for the purposes of having a go, we are looking at a particular type of ANOVA, which is the one I've talked about, which is one way, meaning looking at only one particular variable, that is to say the type of journal that is. we can do ANOVA in more complex ways, but we'll talk about it next time. And we will act as if the data is actually normally distributed and almost scholastic, which isn't, and we will see as we go along that it is not. So as last time, we're going to open our lovely Jamovi data set. And for those of you that are not familiar with this data set, I've kind of used it for the previous lectures. There's a bunch of papers in here, a number of variables. Some of them are nominal, some of them are scales, some of them are continuous, like retreats. So for the purposes of what we need to do, we're going to go on ANOVA, and we are going to go on one-way ANOVA, and we are going to pick our dependent variable, which is a retreat, and we're going to choose our grouping variable, which, as we said, is journal title. Now, last time when we did students T, we used surgical or medical, that is to say 2 groups. Today, because we're doing ANOVA, we've got more than 2 groups. In particular, we've got 6. There you go. And as you can see, Jamovi spits you out very quickly an output, which tells you that, yes, the journal does statistically significantly affect your likelihood of getting retweets. Now, there's a few caveats here. First of all, we are assuming that variances are equal, so we need to check that, although we know it's not true. And we're going to run some assumption checks. As we said, we need to check if the data is normal. Is the data normal? No, it isn't. But that's fine, because we're only doing this to demonstrate how to do the ANOVA. I'm not saying that ANOVA is the right test to do here. Okay, so this assumption is violated. So is the assumption of almost elasticity. We talked about this test, Eleven's test, last time as well. And as you can see, the data is not normally distributed, and the variances between the groups are different. So this is not the right test to run, but I've shown you how to run it for the purposes of doing your own stats at home. Next time, maybe we'll talk about how to do or what to do when your data is not normally distributed, but you still need to do an analysis of variance. So there are variations like Welch test and a few other bits and bobs that luckily Jamovi lets you do, which again is a wonderful software. So look into it, just play with it a little bit. And I'll call it today. I've taken about 15 minutes, so I hope it wasn't too tedious or too complicated. Thank you.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.